H. pylori or Helicobacter pylori is the primary cause of chronic active gastritis. It is a curved gram-negative organism that embeds into gastric mucosa. It damages the lining and can lead to duodenal ulcers, gastric ulcers, and can increase the risk for gastric cancer. Testing for H. pylori is clinically important because eradication therapy dramatically reduces ulcer reoccurrence and cancer risk. We will discuss the different diagnostic methods next. This slide is showing the associations of 90% of duodenal ulcers, 70% of gastric ulcers have this linkage to H. pylori. There's also a six-time or six-fold increased risk of gastric carcinoma in an infected person, which highlights why prompt identification and treatment is required because we're not just treating symptoms, we may be reducing cancer risk. And this is just showing us how H. pylori colonizes along the mucosa and within gastric pits. Its ability to survive in the acidic stomach environment is why it has such clinical significance. Its key survival mechanism is urease, as urease breaks down urea into ammonia and bicarbonate, which creates a protective basic or alkaline cloud across or around the bacteria. This is what allows H. pylori to survive the stomach acidity, and urease activity also forms the basis then for diagnostic testing. Think of the urea breath test because urease production releases labeled carbon dioxide, which can be measured in the exhaled breath. The biochemical trick here is why H. pylori testing can be so accurate. The urea breath test is one of the most accurate, most non-invasive tools for H. pylori testing. The patient drinks urea that's been labeled with detectable form of carbon, usually C13. If H. pylori is present, it uses urease to metabolize the urea, releasing labeled carbon dioxide. That carbon dioxide diffuses into the bloodstream and is exhaled, where we can measure it. Sensitivity and specificity range from 94 to 98%, which is excellent for a screening test. And this is the preferred method for determining test of cure after treatment. Serologic testing looks for IgG, IgA, and IgM antibodies to H. pylori. IgM suggests acute infection, IgA indicates mucosal involvement, and IgG may persist for up to a year after eradication. Because antibodies can remain elevated long after infection, serology is not helpful for the test of cure, and IgG positivity does not necessarily indicate an active infection. In clinical practice, stool antigen and breath testing are preferred. Endoscopy with biopsy is the most definitive diagnostic approach, as tissue can be evaluated by rapid urease testing at the time of biopsy and histological identification, which is the gold standard to visualize, as well as culture, which allows for antibiotic susceptibility testing. But this approach is typically reserved for complicated cases, patients with high cancer risk, or those who have failed eradication therapy. Now, comparing the H. pylori stool antigen, HPSA, versus urea breath test is a common thing we talk about in clinical practice. These are both very clinically useful tests. They have excellent diagnostic accuracy, but stool antigen can be used for both diagnosis and test of cure and is unaffected by proton pump inhibitors, versus breath testing provides rapid results but does require stopping PPIs for about a week. Stool antigen testing is also preferred in peds due to ease and non-invasive sampling. You don't have to drink anything or do anything, it's just a stool sample. Looking again at another more practical perspective, the breath test requires specialized equipment, but is also very patient-friendly. Stool antigen requires stool collection, which some patients don't love, but the specimen stability here is good. Both are highly accurate when performed under proper conditions, and the important clinical point would be to stop PPIs prior to urea breath testing, or else you could get a false negative result. We'll stop here. When we come back, we're going to talk about carbohydrate malabsorption.